Greetings, everyone. It's indeed a great honor and a pleasure to come to you today with, again, what I think is a very, very powerful presentation that reflects a lineage. And you will notice in the background Professor Hugo Parche, the father of modern compression therapy. And one of the most compelling things that he taught us, and many people still don't know today, is the concept of short stretch compression. And as you probably know, if you ever went to the zoo, that the giraffes have these big long legs, but they never have any swelling. And yet they have a venous pressure that's at least 3 times as high as ours at the ankle. And sometimes they're up for 24 hours a day. What's that all about? Well, their skin is like steel. And so Hugo has taught all of the materials that mimic the giraffe leg and short stretch compression. And the other thing that he said many, many times, he said, we have a dose for all of the drugs, but we don't have a dose for compression. So he campaigned and taught early, and with one of his disciples, who's a powerful force in the world, Giovanni Mosti, they came up with a very sophisticated measuring system. And now, and you'll hear later that there's now a simple device that's not very expensive and in good hands is reliable. And you have to know the dose of compression. You must know the dose of compression with people with mixed arterial and venous disease. The other thing that Hugo taught was about the skill is in the provider as far as the bandage goes. And that skill needs to be taught. And he went all over the world for over half a century teaching all of these principles. Now, as he went along, he started what was called the International Compression Club, which sounds like a little social organization. As a matter of fact, it's one of the most powerful organizations scientifically in the world in the area of compression, because it's brought together all the thought leaders for compression. And in particular now, Hugo has passed the torch to Giovanni Mosti, who's a brilliant investigator from Italy, and worked with Hugo, and now has carried Hugo's principles and taken them to the next level. Now the torch is being passed in the United States to Professor Fedor Lurie. And Fedor previously has been on this channel, and he gave us one of the most compelling and beautiful discussions about the post-thrombotic syndrome and the relationship of stockings to help prevent it. And it was very brilliant, impactful. And so I'm so thrilled to have him back here again. Now, Dr. Lurie started his academic career in 1980. He served at the faculty of the Urals Medical Academy, the University of California, Davis, and the University of Hawaii. He currently is Associate Director of the Jobst Vascular Institute and Adjunct Research Professor at the University of Michigan in Ann Arbor. Dr. Lurie's main clinical interest is in venous and lymphatic disease. He serves as Director of the American Board of Venous and Lymphatic Medicine, Director of the Vascular International Accreditation Board of the Intersocietal Accreditation Commission, and is a voting member of the Medicare Evidence Development and Coverage Advisory Committee. Dr. Lurie is the Chair of Science of the International Union of Phlebology. He's a past president of the American Venous Forum and the American Venous Forum Foundation, and members of several committees for the Society of Vascular Surgery. He's an honorary member of the European Venous Forum and several vascular surgical societies. He served as a principal investigator on 21 multi-center trials, published more than 200 original papers, multiple invited commentaries, 27 book chapters. He's the author, editor, or associate editor of 5 books. Finally, he's an accomplished speaker with over 300 publications nationally and internationally. Thank you again, Fedor, for appearing on our channel, and welcome.
Thank you very much, Joe, for a very kind introduction.
It is absolutely impossible to give a comprehensive overview of how to manage lower extremity venous ulcers, but I will try my best to give a really high level points in the management of this condition. Here's my disclosures. I don't really have a direct conflict of interest with this topic. So I will try to concentrate on what's the current diagnosis for venous ulcers, what are key components of the management, and what you expect for venous ulcer to happen when you manage this condition. Venous ulcers are one of many manifestations of chronic venous disease. As such, they can have either primary or secondary etiology, be associated with a broad variety of involved anatomical segments with different pathological changes such as reflux, obstruction, or combination of them. But the C of CAP classification, the clinical class, dedicated only 3 classes to venous ulcers. The first episode of ulceration is C6 clinical class. When the ulcer heals, the limb is classified as C5, and any recurrent ulcers are classified as C6R, R for recurrences. So venous ulcer is not a single episode, but a continuum of clinical classes 6, 5, and 6R. We can heal the majority of ulcers, but the venous disease remains uncurable at the moment, and almost half of the patients with venous ulcers continue to undergo through the cycle of C5, 6R chain classes. The definition of venous ulcer is very specific. Not any wound in the limb with venous disease is a venous ulcer, but only those that occur in the area affected by venous hypertension. For example, this is venous ulcer, although it's not in the typical location of the medial malleolus. On the other hand, this is an example of not a venous ulcer, although the limb is affected by venous disease and have deep venous obstruction. In fact, it is a case of necrotizing fasciitis in the patients with post-thrombotic disease. Ultrasound is the most important tool to identify the ulcer if it is located in the area of venous reflux or venous obstruction. Mapping the reflux path can show that it leads to the ulcer area. Sourcing is another technique. By gently pressing the ulcer, we can identify which vein is connected to the subalcer venous plexus. Non-phasic flow on ultrasound and continuously reverse flow indicates possible proximal venous obstruction. In suspected obstruction, require additional imaging like a direct venography or CT venography or MR venography. But IVUS is probably the best way to more appropriately diagnose the degree of proximal venous obstruction. Managing venous ulcers includes several components. If any correctable hemodynamic abnormalities are detected, they must be addressed. This includes ablation of superficial reflux and normalizing venous outflow. These aspects of ulcer healing have been extensively studied in recent years. However, it's equally important is medical management of patients with venous ulcers, including the treatment of metabolic abnormalities, obesity, and other comorbidities in the patient with ulcer. But the cornerstone of the management is compression therapy. As you can see, this is the only level A grade 1 recommendation in current ulcer guidelines. ESCAR trial was the first attempt to show superiority of surgical treatment of saphenous reflux. What was clear in that compression alone can heal 60% of the ulcers in 6 months and 70% in 1 year. More recent IVRA trial although show better results after ablation, still had more than 75% of ulcers healed in 6 months by compression alone. And Cochrane meta-analysis demonstrated even higher healing rate by compression, 90% in 2 years. 90% of ulcers can be healed by compression without any additional interventions. Not all ulcers are the same. Large size and longer duration significantly decrease chances of healing. Unfortunately, these patients were not included in the randomized trials. The majority of patients, though, should heal in 6 months to 1 year, as we can see from the trials and from the real-world data. So those are expectations when you treat venous ulcers. But if the progression is slow or patient doesn't comply with the treatment, that should be reassessed and taken other steps in the management. Late Hugo Patch demonstrated advantages of patient self-management of compression. Patients apply correct pressure more frequently than nurses and had better outcome, were given control over what they can do with their compression device. Again, ESCAR trial, and it showed that continued compression after healing prevent the majority of the recurrences. This was confirmed by IVRA trial. And what is important to remember is the restoration of skill integrity takes about a month or 2 after complete ulcer healing. So the process doesn't stop when we see that the ulcer is fully epithelialized. It continues for several months, sometimes even longer. And inflammation plays an important role not only in the development of venous ulcers, but also during their healing. It is an interesting aspect of inflammatory process during ulcer healing that it impacts lymphatics. The increase in transforming growth factor beta-1 is essential to ulcer healing, but it has a negative impact on lymphatics. The basic science data show that TGF-beta-1 causes lymphatic fibrosis and lymphatic dysfunction. This lymphatic dysfunction is present in patients with venous ulcers and can be treated with intermittent pneumatic compression. It is possible that compression therapy that continues after healing of venous ulcer addresses the lymphatic component or lymphatic damage and prevents ulcer recurrence, but this is the subject for future studies. In conclusion, management of venous ulcers should include proper diagnosis, appropriate compressions and medical therapy to heal the ulcer and prevent recurrence, and retreatment of febrile lymphedema that is present. And the treatment of venous ulcers doesn't stop with the ulcer healing. It continues because venous disease is still present in these patients. Thank you very much for your attention.
Thank you again, Fedor. I'm sure the audience who viewed this talk will understand how complex and brilliant it is in many, many aspects. And thank you for sharing that with us. Now, when you look at this talk, and you're a medical director of a wound center, this really makes perfect sense. And you have all your pieces aligned very nicely and steps and so forth. What I'm thinking about here, Fedor, is what about the primary care physician? How do we get the primary care physician educated to it? He's not going to become a wound care specialist. And God bless them. They've got to know a little about everything. So what do you impart to them to get them started on the road to handling these problems?
That is a very important issue because primary care providers are the first who are going to see those patients with venous ulcers. Yeah, and it is a challenge. And I would say the first thing you need to do is to look at the leg very carefully and see if there are other signs of chronic venous disease, skin discoloration, swelling, and the location of ulcer in the lower leg, not on the toes, on the foot, but in the lower leg and ankle region. And if it is so, then the first thing to do is to check the pulses. And if the pulses are there, then the patient needs some form of compression before you even send them to a specialist. But you definitely need to send them to a specialist. It's a complicated disease with multiple treatment options, and selection of the most appropriate treatment options is not very easy. So those are steps for the primary care.
Thank you very much. And the next thing I would like to talk about is what about ACE bandages? And does the primary care physician put on an ACE bandage in these patients if they have swelling, or uh, how do you approach that? How do you try to tell them what they need to try to do?
Mhm. Yeah, the compression therapy, as you nicely described in your introduction, is another very complicated area. It looks simple, just a compression bandage, and actually there are a variety of materials and variety of devices, and it's not an easy way to put some of those devices on. Some of them are easy, some of them are not, and the bandages in particular requires a special skill. So the best way is not to do any simple bandage on the patient right away, but to send patient to somebody who knows how to select the appropriate bandage material or compression material. The feeders know a lot about how to choose appropriate stockings if the stockings is an option, or select Velcro device is the Velcro device option. And I have to say that the majority of ulcer patients, if not all of them, will be much better off initially with a Velcro device. Short stretch bandage is, of course, another option, but it does require skill. And it's not very commonly uh, present, the situation when people really know how to appropriately put the short stretch bandage. Velcro devices is much better option.
Now, when you talked about, well, I want to come back to this 1 minute because even one of my good friends said to me, and I've worked with these fitters for 30 years or more, 40 years almost. And I'll tell my own case. I am a specialist in venous disease, and I understand compression very well. And when I had a fracture of my leg, and postoperatively, I was in various forms of compression. And then finally, I put myself in what I thought was there's 5 or 6 good companies out there that make stockings, premier companies. And I took the stocking from one of these premier companies and I put it on my leg, and it was I wasn't right, especially in my foot. So when I got back from the West where I had the fracture, I went and saw my fitter, and she looked and said, "Yes, you've got a very good stocking on there. And if only you had a ballerina foot, uh, the that would be great. But you don't have a ballerina foot. You have a duck foot. So because you have a duck foot, I'm going to put you in another very good brand, but it has a wide toe box instead of a narrow toe box. So beware out there, people just buying stuff off the internet. Those clinicians that treat and fit people, they treat thousands of people, and they have all sorts of nuances, because if the stocking you get on the internet doesn't fit right or do the job, then you got to go to them anyway. So um, finally, what I wanted to ask you about is the role of venoactive drugs. I remember when I first heard about this, oh, you can take a pill and it'll control swelling. You don't need to use compression. Could you give us a little final kind of few tidbits about venoactive drugs?
Yeah, venoactive drugs is a very powerful tool actually in the arsenal that we have. They need to use appropriately. Most of them, they are not the same. There's quite a few of different types. Probably the most popular are either what calls micropurified flavonoid fraction. It's a complicated name, but it's basically a combination of a couple of flavonoids. Diosmin is the one that most commonly used here in the United States. Uh, they act specifically on the venous inflammation. And so when the patients with venous disease and venous ulcers take those drugs, they reduce the severity of the symptoms and help in the healing, but there's no way they're going to be the mainstay in treatment. It's just adjunct treatment. So you have to use them, but when you use other modalities which are appropriate for a specific patient, either surgical or interventional treatment and compression therapy for all of them.
Well, thank you very much, Fedor, and thank you so much for a wonderful discussion and advice to the primary care doctors and also for practitioners around the world that care for these problems. And again, I can't tell you the strength of our channel is having people like you come on and give variety and power and up-to-date information that's good for all of us. So again, thank you very much.
Thank you, Dr. Caprini, for having me on your channel. It's really a privilege to be here, and I'm glad that I have an opportunity to contribute. Thank you.